Welcome to our podcast, PA Mindset Matters. I'm Jessica Spissinger, and we're excited to introduce you to our mini mindset editions.
I am Mercedes Dodge, and we created these short episodes for PAs, PA students, and all healthcare providers who want a moment to pause, reset, and reconnect with purpose.
Each episode, we will explore a reflection, practical insight, or mindset shift you can apply right away in training, in practice, and in life.
Because how we think shapes how we show up for our patients, our colleagues, and ourselves. So let's get started. Welcome to the Mini Mindset series. Jessica and I wanted to do a deep dive, a short, focused conversation on trauma. What we notice is that it shows up in any clinical care practice and office, so we need to know the basics. We're going to go over trauma, not just the trauma conditions we see in the psychiatric practice, but also how can we recognize it in other offices and settings, such as primary care, pediatrics, urgent care, ortho, and beyond. So trauma isn't just rare, it's common, often unspoken, and deeply impactful. So let's dive in. It wasn't until the 1980s with DSM-III where it was formally recognized as PTSD. It was shifting away from Vietnam veterans, Holocaust survivors, but recognizing survivors of sexual assault and starting to talk about that it was real and happening in different arenas. Flash forward, DSM-V, trauma was recognized as its own diagnostic criteria. The focus expanded beyond fear and now started focusing on cognition changes, arousal, difficulty, identity, dissociation. And so the shift really matters because the trauma moved from what I said, the moral failure, which we still see today, to a biological thing happening in our body, changing the way we function, interact, and behave. There was an ACE study called Adverse Childhood Experiences back in 1998 in San Diego Kaiser Permanente, where they were collecting information to help manage issues with obesity. It was a clinic to reduce weight and obesity, but they were looking at the psychosocial measures contributing to the difficulty of losing weight. And what they discovered inadvertently was that a lot of these individuals with chronic comorbidities, including obesity, had ACEs early on in childhood. It was broken down by these 10 questions, and they were about abuse, neglect, family member in the house with mental illness, a parent that was incarcerated. These questions started making us look at trauma differently. The ACE pyramid is something I really think is important to look at because trauma isn't just a psychological thing that can impact us. It's a physical thing that can impact and contribute to what it says, increase of COPD, cancer, disease, and even reduced lifespan. So toxic stress is happening and we need to recognize it and then look at how we can start healing and providing positive factors that can help us prevent some of the trajectory. So how do we actually practice this trauma-informed care as clinicians? So as clinicians, we don't do a great job in explaining how trauma affects people at the biological and cellular level. And what we need to understand is how the sympathetic nervous system changes the way our brain development or multiple organ systems happen. The sympathetic nervous system is the fight and flight response, and especially is activated when we are developing in early childhood. So we're from age like 0 to 5, we're absorbing everything, the good and the bad. When we experience unsafe situations at a young age, that really primes us for how we will react as an adult. And there's going to be periods in our life that even when we are safe, but something tells us we don't belong, it activates the sympathetic nervous system. So we can have acute stress and we can bounce back, but it's when the stress continues chronically that really changes the hyperactivity of our amygdala. One of the things that I like to explain to people is the brain. The amygdala, which is kind of our alert system. Think of the amygdala as a rooster. It's looking for threat, any triggers, and it'll start screaming or yelling. And it'll actually not allow us to put our smart part of our brain on. So our thinking, executive skills, our ability to kind of understand, is this really a danger or not? And that's called the prefrontal cortex. And that's going to be the owl. The owl is our prefrontal cortex that allows us to make calmer decisions. Over time, what we need to do to help our brain is to build coping tools and to be in a safe environment. The more we have those self-regulation interventions, the more we're able to manage the overload from acute stress. But when it's toxic stress, the biggest thing that we need to focus on is coping skills, safe environment, someone that's trusted that can help you feel safe. So at the end, if this is over activated, it'll create changes in the body, like I mentioned in the cascade, increased heart rate, glucose, and it will lead to the long-term consequences. So talking about trauma, when is it diagnosed as PTSD? This is just a quick overview. There are more than PTSD in the DSM-V for the trauma-related stress disorders, but for PTSD, to have certain types of symptoms in these clusters of categories, and to have it more than 1 month, it has to impact your life and functionality, and the trauma itself has to be some specific exposure to actual threatened death, serious injury, or sexual violence. The clusters are intrusion symptoms, avoidance symptoms, cognition mood symptoms, and the last cluster is arousal and reactivity. When we talk about treatment, we're talking about medication, but the goal is to treat the individual and stabilize the biology, like I mentioned. So therapy is really critical. So I wanted to mention the medication for PTSD. The most common ones are the SSRIs. The ones that we use often is the sertraline Zoloft, fluoxetine Prozac. They help the physical overreactivity that we may be experiencing from the trauma so that we can get therapy on board and work. Because a lot of my patients have difficulty working through therapy because their symptoms are too hyperactive. They're hypervigilant. If we can dampen those symptoms, that's when we can do the real work within therapy. So if someone comes in with PTSD and they're wanting to start medication, this is a really good step, but you're not going to just do prazosin. You really want to focus on the SSRIs. Prazosin could be an adjunct. Clonidine, guanfacine, we see this a lot with children that are experiencing some trauma from a traumatic experience. And you can add guanfacine or clonidine, but again, SSRIs are still the first line treatment. What is contraindicated, I think it's important to talk as clinicians, is like, don't do benzodiazepines. It has shown that it may worsen the arousal symptoms, and then we have increased risk of dependence.
The other thing too is like, I think a lot of people confuse a flashback reaction with a panic attack. And that's where the benzos, I think, are clinically confused. If people are coming in talking about having a panic attack, not wanting to be forthclosing about their trauma history, then it gets misdiagnosed. And the problem with the benzos is they're kind of negatively reinforcing because they work so well. Just one point there too, one of the other reasons why they're contraindicated is because with the trauma, you're more likely to be prone to that dissociative state. And benzos are literally hypnotics. And so they'll put you into much more of like a lower threshold to have a easier like trigger to dissociate.
And I think you brought up so many points that it was hard to do this quick review. We, as clinicians or as people, talk about zoning out or can't focus or flashbacks and dissociation, and trying to really understand what's happening and getting a good trauma history and understanding these symptoms start. And was there any life event that really was changing for you and your functionality? I do think that when we hear flashbacks or nightmares, sometimes we're quick to be like, here's a medication. But in reality, especially for my kids, is like, oh, a nightmare. What's going on? What is the unconscious trying to uncover?
Let's do a little dream analysis.
Not that that's my role at every visit, but asking them to think about, this is a reaction your body is doing, and what can we take from it? SSRIs are the first line. I never want people to hear that nightmare or a flashback and just go directly to medication. It can definitely help, especially if it's creating a dysfunctional sleep pattern. If you're not sleeping, if you're only sleeping 3 to 4 hours, we got to change that, or you'll never get improved mood cognition the next day. Like, you'll always feel like you're failing. So that's when you have to look at the risk and balance for the medications. So I think the pivot, the trauma-informed care, is where I think that helps people understand it's not a clear, like, I have trauma, here's a medication. So what I think the pivot here, or the reframing, is as clinicians, as human beings, instead of seeing anger or irritability or someone that's losing focus and they have trauma, it's not that what's wrong with you that really treats with the lens of pathology and judgment. And we need to start shifting our thought process, like what's happened to you. And so that opens the door of curiosity as a clinician to really meet where the patient's at. And not saying that you will understand it completely, but if we kind of start thinking about what happened to you instead of what's wrong with you, I think it's a really good shift. So this applies for children and adults, regardless whether someone meets the full criteria of PTSD, right? Adverse child experiences, any types of adversity really shape behavior, physiology, relationships. Toxic stress is not a diagnosis in the DSM-5, but it's really a process. The good news is that if we start practicing trauma-informed care as clinicians, as community members, and we routinely screen, educate, support patients and families, it will start changing how stress affects the brain and the body.
That's one of the things that was really landmark with PTSD as the diagnosis in the DSM, kind of recognizing for the first time that people are coming with an external etiology, because that's one of the things that the DSM has. There's no biomarkers, no etiology, but with trauma, I always call it like a BYOE, bring your own etiology. Just like you said at the beginning, the external situation does wind up leading to some internal changes.
So across psychotherapies for PTSD, across adults and children, these therapies that I listed, they work best for trauma with the following core principles. They reduce avoidance to directly address the traumatic experience and help patients rebuild meaning and connection in their life. So in adults, the strongest evidence is trauma-focused CBT, EMDR. Prolonged exposure is another therapy module, and cognitive processing therapy. Let me focus on the trauma-focused CBT because it did show up on both, right? Both age groups. So when we talk about trauma-focused CBT, the framework that I like to think about is practice. P is for psychoeducation. As clinicians, we help patients understand that they're not broken and that the nervous system needs adaptation. Then we have the R, which is regulation, learning how to calm the body, recognizing emotions before the escalation. C is for cognitive coping, separating trauma-driven thoughts from current thoughts. That's why I like breaking it down, what you have control over. T is the trauma narrative. You gradually and safely follow the mastery of that and facing avoided triggers or the reminders in real life and kind of bringing it back to that it's not happening today. So it's a lot of reframing, a lot of support with a therapist. So this is done with a lot of trust and support, but it definitely works. C means conjoined sessions. So you're working with therapists, and E focuses on enhancing safety and future. So basically, there's a lot, just a review of the base, highly effective modules. But in short, these psychotherapies help teach skills. First, looking at the story, and then throughout the whole therapy modalities is making sure you feel safe. So definitely find a trusted therapist and make sure that you're seeking this as early as possible. At the end, what I really wanted you to get out of this is just think about trauma-informed care. The goal isn't just symptom reduction. We need that to move on, to grow and heal. Healing includes kind of that shift in our brain is what's wrong with you, what's happened to you as clinicians thinking that way. And then as patients, that shift on I'm damaged, I'm broken, shifting that to I survived, I'm strong, I'm resilient, helping them see the future beyond trauma is possible. And I always want individuals to know that these interventions work. The first thing is to talk to a trusted clinician. Connection is one of the biggest pieces of trauma-informed care, is that building that alliance, the therapeutic alliance is as powerful as medication. The more as providers that we feel comfortable talking about trauma, talking about how it changes our nervous system and our physiology, I think is really critical. Medications is really helpful. It can be helpful if you use it with a strategy, but again, not as a reactivity, as in like, let me give this to you because you're a nightmare, right? Let's look at the big picture. And just be careful with the benzos. It really interferes with the trauma processing, like Jessica mentioned. And basically just continue to work on your own self co-regulation. I think one of the things as clinicians, we also experience secondary trauma or vicarious trauma is what they used to say in regards to hearing people's story and hearing what they bring. The more we practice our grounding tools, what do we have control over, what we don't, make sure you're doing your self-care, do activities and hobbies that bring you joy, seek therapy as well if you feel like you are in a place where you need support. So that's basically my summary. Well, that's a wrap on the deep dive on mini mindset for trauma. Thanks for joining us.